The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. So welcome everyone today to the Success in Practice podcast. I'm joined today by the lovely Alison Linn. Alison is the owner and operator of Rozelle Osteopaths in Sydney, Australia. She's been a qualified osteopath for 37 years after completing her osteopathic studies at the British School of Osteopathy in 1987. She worked in the UK for 3 years, then moved to Australia in 1990. She worked in 2 multidisciplinary clinics in Sydney, and also began teaching at the University of Western Sydney's osteopathy program in the early 2000s. This was my first encounter with Alison, and at this point, I'd have to say that she was a real breath of fresh air as a tutor for me. She was always very approachable, down to earth, and very humble. Now, speaking to Alison, this seems quite strange, given her upbringing at a girls' private school and her describing her childhood as getting spoiled. Now that her children are all grown up and she leads a very active lifestyle as a competitive outrigger canoeist. She still practices 3 days per week, and whilst being a great generalist, she is enjoying seeing dysfunction related to the head, face, and in particular, vocal disorders. She is almost as good as an osteopath as she is a person. Ladies and gentlemen, I'm always pleased to chat with and welcome the lovely Alison Linn. Alison, welcome to the podcast. I'm very honoured, and it's just great to chat to you. How are you?
I'm very good, and thank you for inviting me. It's great to give an opportunity to reflect upon my career to date and to be able to share insights and experiences.
Yeah, well, we'll get to that, and but I think the best value we can give people today is to really explore your views on some specific clinical conditions.
Yep.
And that would obviously include the head, face, and vocal cord disorders that I discussed earlier. But I'd like you to specifically also tell us about your rationale when treating, and maybe talk about your early career. So I think that's important for people to kind of listen to experienced osteopaths discuss their own rationale and how they base their treatment on osteopathic principles. You recently also ran for a board position at Osteopathy Australia, so I'd like to discuss your motivation around that.
Yeah.
And also, you have plenty of experience to share with us in terms of mentoring many young osteopaths. So we'll discuss some of those experiences as well.
Yeah.
Is there anything that you'd like to chat about that I've maybe left out, or is there anything you want to?
I'm sure it'll come up.
It'll come up. Yeah.
It'll come up.
Yeah. We'll rabbit hole down somewhere, I'm sure.
Yeah.
All right. So before we get to some of the clinical stuff, I just want to talk a little bit about your background. You grew up in the era of Margaret Thatcher.
Yes.
Now, I'm a big fan. And how was it growing up in that era in England? And how did that influence you? What lessons can you draw for us about her impact on you personally?
Well, I think for the first time in history of Britain, if you came out with a graduate degree, you weren't guaranteed a job, whereas before at a degree you got a job. Yeah. So it was the first time we were seeing unemployed graduate anything, and that really sort of struck a chord, because it was a guarantee that, you know, get a degree, get a job. And also there was a lot of strikes on, there's a lot of difficulties, a lot of redundancies being made as the world went from, you know, hand created cars to everything became automated. So that really affected me in my outlook about, you know, what I wanted to look for in a career. And so I meshed that with what I liked, which is biology at school. So I thought, well, what works, where is there little or no competition for jobs, and where would I find something that interests me in terms of the body, and osteopathy kind of fitted the bill. and
Okay.
I was about 16.
So her particular views, though, and her particular kind of,
Yeah.
I guess, ideology or her views on leadership and her views on government, listening to her talk and just being a part of that kind of that time, did that shape you in any way, like in terms of, having more of a competitive spirit,
Yeah,
that kind of thing?
sure. For sure. Yeah, definitely. And she was the first sort of prime minister, female prime minister. So it made you think that, there wasn't necessarily a glass ceiling. And it was around that time that you heard more and more about women not working for other people, having their own businesses, competing with men in, a male market and doing well. So it's the first time that was happening.
Yeah.
And, women were stepping up a lot more.
And so moving forward, you arrived in, I think you said in Sydney in 1990.
Yeah.
And then you began working here in a couple of different clinics to
Yeah.
kind of just get your feet wet.
Yeah.
Fast forward to today, right? What does your clinical week look like? What does a normal week in clinic look like for Alison?
It's pretty busy. Look, it's mainly just me in the clinic. I think with the onset with Clinico and those sorts of things nowadays, you just, you don't need a receptionist anymore, particularly when it's just one or two of you. It really has made it quite redundant. I did have a receptionist and they just sat around doing nothing. So it really is me going into the clinic and doing everything. So there's quite a lot of micromanagement as well as the sort of face-to-face osteopathy. I start at 10 o'clock on Mondays. I think it's bad for your health to start any earlier on a Monday morning. I like to sort of ease myself into the day. But I do always get into the clinic about a good half an hour, 45 minutes before anything kicks off. So I can just troubleshoot anything, just mooch around, tidy things up, and then just sort of get ready, sort of, meet and greet and start doing the clinic.
Yeah,
so,
right.
And I do 3 days a week, but they're the long days. The Mondays 10 till 7:30. The Wednesday is 7 a.m. till 7:30, and the Thursday is, if I do, they can swap around those days, is like an 8 till 7:45. So the long days.
Right. And so let's kind of discuss it. You're still doing long days, and when you're it seems like that when you're at work, you're at work, like,
I am, yeah.
And so talk to me a little bit about, you're from a different era, and you're from a different generation. Talk to me a bit about the aspect of hard work. Like, this comes up a lot with a lot of the students and a lot of the people that I'm discussing things with at the moment. And it seems like they've forgotten that no matter what you do, that hard work is actually a main ingredient in the recipe for success.
Yeah.
So tell us a bit about that. Like, when you're there, you got to work hard. And has that been your experience in terms of
it is. And I tend not to mix the admin days with the treatment days. So even though I'm not working, I'm not at the bench on the Tuesday and Friday. I'm doing reports, doing the admin for the clinic. So that'll take up the 2 half days, on the Tuesday and the Friday. So, but yeah, I'm just sort of there. I'm there to work, and rather than scatter everything throughout 5 days and mixing the admin with the hands-on, which just I didn't like. I like to portion them and separate them out, and at the bench, or I'm doing my admin and reporting, and I separate them out quite a lot. And I don't mind a long day, and I do actually stop off though. I'm fortunate to have my gym next to me that does HIIT. It's half an hour. Belt out the clinic, do my HIIT, run back in, got a shower, jump in the shower, come out, ready for the patients again. And I do that mid to late afternoon at that classic time when you sort of start to droop a bit, 3 or 4. That's when I do it, and I'm hitting. I'm just alive and kicking for the rest of the patients. I can't believe it. They say you start at 7 and you're still here at 7:30. Go, yeah, I feel lively. I've done my exercise, and I know how to, keep the endurance going.
I guess I'll segue into then asking you about how you really use your body in practice. Like, you know, are you someone who's thoughtful about your own use of your own body, and especially to a lot of the female listeners that are listening in or watching? You know, what kind of tips can you give in terms of longevity?
Well, I mean, our style that we were taught by Hartman and Kyria and Korth and all those people in this 80s is a very robust style of osteopathy. So it's actually, you know, a very physical style of osteopathy that I do. You're very on the patient and moving around and moving them around. But it depends what I'm doing. You know, I'll do a bit of cranial, I'll sit down, you know, be as still as anything. So it depends what it is like. But I am, it is robust what I do. And I think, and I'm very, very, very strict about my own posture. I just don't even think about it, but how I do things. That was very much drummed into us in the 80s, you know, your body positioning, your posture, you know, looking after yourself. And you may not recall, but when I was in, you know, teaching technique, some students I would fail because they weren't positioning themselves very well, and they would question. They felt they'd done the technique perfectly, and I'd say, "It won't last a year or two if you do it like that, though." And I've been saying this to you for a few weeks, and you're still not listening. So, you know, fail, but there's always repeats, and they'd be okay. But it was just a drum it home. You're not going to last if you. I mean, there's also bad luck. Some people have bad luck, and some people just have sore backs and necks anyway. But you know, I'm very strict about how I position myself, and my footwear, and sort of stretchy, non-restrictive clothes.
You've obviously you spend a bit of time conditioning your own body as well. How important has that been for you?
Oh, I've always done that. So, yeah, I've always either done yoga. I used to do yoga at lunchtime, like I used to do the hour of power when I used to be in Rozelle, and it was across the road. I used to just run across the road. It was just great to have these things opposite me. I've always done something, either whether it's Pilates or, you know, for a few years, I was just getting up early and doing boot camp for every morning at 5:45. That was great, but after a while, I felt a bit overdone. And I thought I need something calmer. I did Pilates for a year, got bored of that, back in the gym. But HIIT is perfect, half an hour.
Yeah, good.
And yeah, it's, you know, I keep myself physically conditioned for the job, you know. Because going about, you know, I say to my patients, going about your day-to-day business doesn't keep you fit enough for your day-to-day business.
No, it doesn't. You need that extra bit of resilience when things get a bit extra for you as well.
Yeah.
And so also the outrigging, the canoeing that you're doing, that's tough on the body. So that helps you as well.
That's endurance. You know, we can be paddling, you know, sometimes I'm on the water for well over 2.5 hours in my own canoe by myself in the open water. Or it can be, you know, about 2 hours, 2.5 hours in crew. But yeah, that is endurance. You don't stop. You get in there, you don't stop. There's no lay down Sally. You don't stop.
In terms of endurance in practice, I mean, you have to give the last patient of the day the exact same energy as you gave the first patient of the day.
Exactly.
And is that something that you feel like that you've achieved in terms of continuing that and also getting your own health around that particular concept?
Yeah. I very much make, you know, everybody gets the person who sees me first is the person who sees me later. And in fact, I had a patient recently who always sees me in the morning. She had me last thing for a change about 2 weeks ago, and she said, "How do you do it? You're just the same now as you are at 8:30 in the morning." I said, "Well, you know, it's training. I've got used to it, but that's how I do it." And I said, if I couldn't do it, I would then most likely give myself a bit of a break and work every day, but do shorter days, like Monday morning, Tuesday afternoon, Thursday morning, all day Friday. You know, I would break it up into sections if I felt I wasn't able to do that.
Well, it's rinse and repeat as well, right? So it's like the more you do it, the more you get conditioned to it. So
it's just, and I'm just able to do that sort of endurance stuff.
Yeah, good. And so a lot of us just roll your sleeves up and get in there and get it done, I guess. You know.
Yeah.
And so when you at the moment when you're in practice, you're a generalist normally, from what I understand and speaking to you previously. But at the moment you're becoming more interested in conditions of the head, face, and vocal disorders as well. So
Yeah.
tell us what led you there. Like how did you get to
Well,
that?
I think if you look at the pain disability list, it ranks number 4. I think it's back, then neck, then something else, and then it's number 4. But it's the least understood and least managed. And when I go and talk to the first place I worked at was a multidisciplinary clinic with quite a lot of GPs, and then another place I worked at fairly recently when I shifted clinic was amongst a load of GPs, and I go and hang out with them. And recently, particularly when I said, you know what, I know I'm a generalist, but I'm steering towards this. They went, nobody knows what to do with that. No, they said we just kind of don't know what to do with atypical face pain or atypical head pain. We just don't know what to do. It's generally we'll send them off to get see an ENT, get a brain scan if that's so. What happens if that's clear? We don't know what to do. We'll give them Lyrica. We'll do this. We don't know what to do. One of them said, "Oh, I've got a TMJ physio," and I said, "Have they trained in TMJ? Or they're just saying that?" She said, "Oh, I don't know. They're just a new grad." I went, "Well, they're probably just trying to reap that in." And I realised there was an enormous hole there. That there's a lot of people with atypical head face pain or voice disorders, and there's nowhere for them to go. There's nothing there.
So what are some of the common conditions that you're seeing? Like, are there any specific conditions that you're seeing at the moment that you can discuss with them?
Buckets of TMJ.
Yeah.
Buckets of TMJ. Just, I would call it atypical. There's the other one, atypical head pain, where they've just got pain on their head and they don't know why, and nobody knows why. It's not intracranial, it's extracranial. Headaches, migraines. Let's see what else. People with, suborbital pain around their eye. They just feel like there's a pain in their eye. Sinus people.
Sinus, yeah.
Waiting sinus. People who get sort of getting sort of pain in their teeth, but their teeth are fine. And around that sort of just give you a loose idea.
So when you see these types of patients, and how are you using your osteopathic rationale to kind of start to get to the bottom of this dysfunction? Like, what's the I mean, we know principles are principles, and applied to the hips or applied to the head and neck and face, they still kind of stand true. But how are you? Be specific for us, just to give people an inside look at what kind of things you're looking at. Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode, and please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
case history, asking questions, knowing how to ask the questions, following down a rabbit hole to pursue a little bit more, exploring their past medical history, familial history. It's getting that case history down. Right. And then, it'll be sort of hands-on, just checking TMA dysfunction, cranial nerve testing. It'll be all what we call clinical methods. Yeah. So it'll just be using things to working out my differential diagnosis, and then funneling in, but sort of tunneling in from there. I mean, there are times when it's not a diagnosis; it's a working hypothesis, and that's what I say to my patients at the beginning. Sometimes the diagnosis is easy, and sometimes it's a working hypothesis. Sometimes it's a diagnosis, and I change my mind. I go, actually, I don't think it's that anymore. It's this, and I don't mind. I have no problem about changing direction.
Right. Okay. Let me dig a bit deeper there. So you've got a working hypothesis, and you're kind of you're doing things as you go along. You'd expect people to be a little bit daunted by that, because it may seem that you don't know what you're doing, but yet they're still trusting you. Yeah. There's still a level of authority there that you're getting from the patient. Yeah. How are you able to achieve that? I mean, what's the key there in terms of being able to still achieve that level of trust from the patient, even though you're kind of just winging it? When I say winging it, I'm not saying you don't know what you're doing, but you're kind of following the rabbit hole, right? You don't really know what's ahead of you, but you're following the rabbit hole.
I just explained to them what I just said, that sometimes the diagnosis is plainly obvious, and sometimes it takes a while to track this down. It might need further testing, and I say, and sometimes these things do stay quite unclear for a period of time, and the patients seem to be quite accepting of that.
So what you find is that when you tell them what your experience has been,
a working hypothesis sounds like a diagnosis anyway. Yeah. You're still saying something. So look, I've got a working hypothesis, and I still have something to say. I think, well, it could be this, it could be that. I actually think it could be all these things. And my expression often say, I think they're all different tentacles on the same octopus. It's how I often describe these things. I said, it looks like this, it looks like that, it looks like that. And there's no reason why you wouldn't have all these things together. And I think, in a way, they connect back to the same head on the octopus. They look like different things, but they are the same thing.
And so what you're telling them really is that you still have an idea of what's going on. Yeah. But you're being honest with them, right? So that honesty kind of demands some respect, like you're not trying to, fib your way around what's going on, or kind of hide the fact that you may not have the whole picture. You're being very honest with them and telling them that you have what the tentacles are. Yeah. You're just kind of following the rabbit hole back to the octopus.
Yeah, that's right, pretty much. And then, I'll say to them, look, I know what your tissues causing symptoms. I'll say, look, I know what tissues are causing your symptoms, but I say to them, but that's not a diagnosis. Yeah. I say, often people will say, oh, it's your hip flexors. I say it's not a diagnosis.
That's not a diagnosis. That's right.
It's an observation.
That's right.
It's not a diagnosis. And I say, I'll tell you what's causing your symptoms, it's giving your symptoms, but I'm more interested in being a detective and finding out why you've got these tissues giving you these symptoms, and that's going to take a little bit longer, and that's the working hypothesis.
Yeah. So you're explaining everything out to them, and that really achieves a level of authority and trust. Yeah. In any case, really, and I think that's a good lesson for a lot of the younger practitioners, is that when they don't know what's going on, because they're gonna not know what's going on more often than what a 37-year experienced practitioner is not going to know. And if you use the same kind of tactic of being honest, it's not a tactic, it's honesty. If you tell people, look, I'm going to get to the bottom of this is what I think is happening,
and nothing's immediately
apparent, people will give you some leeway, because at least they know that you care enough to be honest with them.
They don't even question it. Yeah, I've never had people saying, "Oh, I don't like the sound of that." That you don't know what's going on. Saying, "Well, it's going to take a little bit of." I say we've got to play detective here.
Yeah, good.
They're happy with that, and that's.
Sorry, go ahead.
And that's that's my patients don't seem to question it, and I don't think it's the authority, although she's got a lot of experience necessarily. I think if you take that line, even if you're a fairly new graduate, people It's that communication.
It is the communication.
It's talk to your patients, talk to your patients, talk to your patients.
Yeah.
You know?
And what are you finding in terms of technique? What's working well for you? I know you've just completed a course.
Few courses.
A few courses. The latest one, I think, was a BLT course or a...
No, it was Lisa Di Stefano. She's
That's
an
right,
osteopath
yes.
from Michigan,
Yes, yes.
on the treatment of the cranial sutures. So it wasn't craniosacral, it was treatment of the cranial sutures where you override the mechanism.
So tell us a bit about that, and then maybe tell us a little bit about what kind of techniques you're using mainly in your treatment of the head and facial disorders.
Head and facial disorders. Well, yeah, with the Lisa Di Stefano, there was a lot of extracranial holds and intraoral techniques to release off the cranial base, and the treatments to the front part of the cranium and the posterior aspect of the cranium as well. And the same for the Baral course I did on manipulation of the brain. That was ways of influencing blood flow, lymphatics, and just shifting around those cranial plates and sutures.
Yeah, right. Okay. And that's what you find is working very well with these.
Yeah.
Yeah.
I've really, it's really given me an edge on the management of head and face pain and neck pain and people's sinuses and people. I know just all. I've got a patient who'd had a brain tumor and she's lost the sight in one eye, and just the eye feels really screwed up all the time. So I was just using this eye unwinding technique because there's 6 muscles to the eye, and this eye technique, and she's just like, she's not got this boring pain behind her eye after 2 treatments.
Yeah, wow, amazing.
And everybody's just sort of said, oh, it'll pass, or it's just migraine. It wasn't. It's not migraine.
Yeah,
but,
right.
yeah, I'm enjoying using those, and the started Caroline Stone stuff on the sort of oropharyngeal treatment of the oropharyngeal for voice disorders. And I use that still, and I just bind it all in. Half the time, it's just like the chef doesn't need to look at a recipe book anymore.
No,
and that's how I kind of feel. I've done a lot of courses in a lot of different fields.
Yeah.
And I just liken it. I always say to people, I feel like it's like going to a hotel buffet. Yeah. And you've got all these choices and of all these skills, or all these choices, and I just pick them out according to what that person needs that particular day.
Yeah. Well, you're expanding your toolbox.
I've got no template.
Well,
I have patients saying, "How can we do something different every time?" Well, you're different every time.
How do you find that? I mean, you're quite experienced, and you're all in on osteopathy. I mean, you've been doing this for a while, and you understand principles and you understand your foundations. Imagine that you were a new graduate and you kind of hadn't really got the grasp of the foundations, and you went and did all these courses. Do you think that would be as beneficial? Osteopathy, kind of the foundations of osteopathy, the principles and what we do, if that's not always in the background.
Yeah, I think knock them down for the first year or two and just start weaving together what you've learnt.
Yeah.
And then weave that in and blend that in with what you're learning from being at the bench and what you're learning from your patients. They'll teach you an awful lot, whether they're speaking to you or not, or you're feeling it. I would say, knuckle down the first year or two, just let it all sink in, let it blend in. And, I still remember being a new graduate and thinking, well, how do you compile a treatment?
Yeah, how do you put it all together?
How do you put it all together? So I would just go, and I still do this sometimes. I think, okay, I'll do some lumbar side bending gapping. Okay, done that. Got a bit of change. What should I do now? I might do a bit of flexion. What should I do now? That still happens sometimes.
Yeah.
But other times my hands just run away with me and I'm going, oh, here, look, there's a rib up there. I can feel the rib from here. I can feel the rib up there. I'm going to, better sort that out to come back here.
Yeah.
But I'm still sort of thinking, I better still sometimes do that thing. I'll just start off with some lumbar gapping, because that's the first thing I ever learned was lumbar side bending gapping. And I still think it's one of the best techniques around.
It is.
I just think it's a fantastic way of just you can still see the patient's face, you can still talk to them, and you can feel all the gross movements and the changes, and and it starts to help the discs imbibe a bit of fluid. You passively gapping the joints, the tissues are expanding, get a bit of blood flow going. It's one of the nicest things you can do to a back.
Yeah, a bit of springing. It's a lovely little technique.
Mm.
All right, so I mean, even you've described, in an early career, how sometimes you, and even now, that you just go, well, I'm not really sure how to put it all together. Looking back at your time when you've mentored some of the younger practitioners, even some of the students that you've taught over the years, what have you found to be some of the traits of the ones that have gone on to become successful? So what are you seeing common? What do you see in common between the practitioners that kind of like end up going on and doing some really good things in clinic versus people that might plateau or fizzle out, as we might say?
The ones who did well at college, were high scoring, they go on to do, who are successful in their exams, and they attended, they didn't dodge on lectures, and they just went head down, bum up, and they were quite, not high achievers, but they did really well in the theory and in the exams. They're the ones who generally that passages on into their working life.
Right, and that was your experience in college?
Yeah. The successful ones are the ones who are already very driven as students.
And do you find that did that continue on when you saw that as a teacher? When you were at UWS and even currently seeing some younger osteopath come through, are you finding the ones that are kind of driven in terms of their university career or the university time, are they the ones that go on to do some great things?
Yeah, and either great things within the community or just become very successful practitioners with the businesses. Yeah, that's what I've seen. It was the ones, it was students who asked the questions. It was the students who are always there at the classes, the ones who are always in clinic, used to come and grab you, used to want to see the patients in the clinic, who you could just see them really focusing in.
Enthusiasm.
And enthusiasm,
yeah,
enthusiasm, right. And drive. You see that rolls on into their working life.
Yeah. Okay. And are you still current? I mean, at the moment,
particularly your year, we're really full of like a lot of driven men and women in your year. It was quite a pushy big year.
Well, yeah. Hopefully that's a good thing. And
yeah, it's good.
Yeah, it was good having you guys. Well, you specifically anyway. But I said in the introduction, you were a bit of a breath of fresh air, because a lot of the lecturers that we had back in those days came with a certain aura of I didn't know of you, and you came in, and it was like just having a chat to a friend at the pub. It was kind of like that. And yet you were still a wealth of knowledge, and you happily shared that with us, and it just made the place very comfortable. And I think that always makes for a good learning environment.
And I wasn't afraid to take on those because you were teaching HVLA with big levers, and I was horrified when I was like, what's going on here? What's all this big like lever stuff? No minimal leverage compression. I was absolutely horrified. So I had to come in and do battle just to kind of get some change, or introduce that as another way of manipulating necks, for example.
Yeah, well, that was a good introduction for us, because we had those big levers going on, and to learn some minimal lever techniques was good. I guess the next question I have, I'll get back to HVLA, and I want to kind of talk to you a bit about that. Do you need a million ways to skin a cat, Alison? Do you need to know 10 different techniques to move the first rib, or in practice, in real life practice, are you using maybe one or two?
You need to know quite a number, because I always say many ways to skin a cat. I always say many ways to crack a nut to my patients. Some people you can wing them, and some people you can't. Some people you can cuddle them, some people you can't. Some people you can spring them, and some people you can't. You need a number of, like, some people, you do their lumbers. they're only adjusting with just like a mainly side bending component, rotatory. Some it's like you'll do like that banana bend, or what we call Chicago. You need a number of different techniques.
Yeah.
For particularly adjustment.
Right. And
doing HVLA.
Yeah, and obviously different body shapes as well, different body types, bigger guys, smaller guys. The hardest ones I find are the little ladies.
Oh, little skinny ladies with tight, with knobbly bones and tight fibrous tissues. Oh yeah, I know. I always say that. They hurt.
Has that been your experience as well?
Yeah. They're sort of hard to shift, and the knobbly bits, they actually quite hurt your hands. You're like, oh. Doing it like working on the sacrum, doing a sacral float or something. It's like,
yeah, that's like, yeah, you could really feel the sacrum, right?
Yeah, the little knobbly bits
or little,
your hands,
or little bumps in their sacrum.
Yeah.
I mean, that's, you would think we'd like that, but somehow, some reason, we just want a layer of fat between us and the patient.
Yeah. Because often my patients go, "Oh, I'm scared of." I say, "Look, drop your hand, drop your bum down. I'm scared of squashing your hand." I say, "Don't know, you won't." I said, "The worst ones are the skinny little bony ladies. Don't worry, you're wonderful." And they're like, "Oh." They think it's weight, but it's the knobbles.
Tell me a bit about some of the work you've done with Rozelle, or with a lot of the techniques that he's kind of
he's
pioneered.
Fascinating. I mean, it's interesting. He's spent his life getting up at 6:30 in the morning, and he spends his first half an hour looking at an anatomy book, and that hasn't changed. That's what he's been doing for decades. And I was like, wow. He has a cup of coffee and then gets out his anatomy book half an hour at 6:30 every morning. And so it's interesting to hear that it's anatomy. He just stares at it and works things out. But yeah, he's just sort of taken osteopathy to cover the whole body, hasn't he? He's sort of, it's mainly all behind bit. We didn't do all the tummy bits, but he's introduced like all the visceral techniques and pelvic techniques and urinogenital techniques, although they're getting a lot of traction here as well. There's quite a few people doing those lectures and covering that now, and interthoracic stuff. It's just fascinating that the breadth and scope that you can get now with osteopathy. It's not just necks and backs and knees and feet and diaphragm. It's you can expand it into any direction you want.
You can really, yeah.
A lot more scope than it used to.
Yeah, I remember having that textbook, the Rozelle textbook. For the life of me, I can't remember.
Visceral techniques, I think. Visceral manipulation. Yeah, there's 1 and 2. Yeah. Yeah,
those 2 volumes were at John's clinic when I was going through as a student, and they seem to be go-to books for anyone at that time that was just getting into any kind of visceral work. So.
He's written about another 18 books since then, 15 to 18 books, including, all that neural flossing, cranial, peripheral nerve treatment, cranial nerve treatments. It's, because, we were taught, we treated joints and tissues. We weren't taught that you could treat the nerves, that the nerves would respond indirectly to what you work, but it's direct work onto the nerves.
Yeah, the interesting thing with that is that you're right. We're taught to treat the joints, the tissues, the connective tissue, and then we think that the nervous system reacts to what we do, and it does.
Yeah, it does.
But there is a greater emphasis now on being very direct with the nervous system, not just in what we do, but I think in medicine in general. They're kind of finding out a lot more direct work on the nervous system. Even a lot of, if you even look at a lot of personal trainers now, they talk about, sympathetic, parasympathetic, whereas, 15, 20 years ago, you'd never hear a personal trainer discuss, those words in their dialogue. Look, moving on, I want to ask you a little bit about your particular views on how you see the future at the moment of osteopathy in terms of in Australia. I mean, you live here now. We'll count you as an Aussie, and you've been here since 1990. And how do you see the future for osteopathy in Australia, in particular New South Wales, because that's where you are?
Yeah.
Do you have any concerns? Do you have any? What are the opportunities?
The future for osteopathy, actually, I suppose it's interesting watching osteopathy evolve, because at first when people, osteopathy is a vocational subject, it's a vocational degree like law, but it's become like law in that people who practice law don't necessarily go out to be lawyers. They used to, but in the past many decades, it's, they go out and do other things. The law degree takes them out into other branches. They don't have to practice law in an office and, give people legal advice. And the same for osteopathy. It used to be, it was always about you graduate, put your shingle on your door, you got your bench, and you get going. Get your phone line in, you get going. And it was, at first, it used to surprise me when I used to hear about the odd person who dropped out of being an osteopath or used their degree to get them to be a medical rep or something like that. It always surprised me. Why do they do that? But in fact, I'm quite impressed the way it's become a bit like law in that sense. You can take it anywhere and do anything you want. I just saw something the other day where a guy was talking about how he really enjoys working in New South Wales, going from place to place, advising on ergonomics or OH&S and that sort of thing. He said he loves it. Sometimes he works from home. It's based in Sydney, Parramatta, plenty of other jobs out there, and it's good money, and you get good support and you get good training. I was like, wow, so he's not hands-on, but it's taken him to that. And some osteopaths become medical reps or go off in other directions or further into research, because there's a lot more research and PhD and that sort of thing nowadays. So I love the fact that it has changed. At first I was a bit purist going, to be an osteopath you have a shingle outside your door and you have a bench and that's an osteopath. But I see it as a qualification that people they've taken it out into the NHS in Britain. We're now involved in NDIS and in Medicare, and I think they've got osteopaths working for the NHS, and I think it won't be long before we really have osteopaths working for Medicare as well, in the Medicare system.
Hopefully there's some acceptance in the hospital system as well. I think.
Yeah. So, if it's happening in Britain, it'll happen here. And so I like the way it's going in that there's a lot more sort of expansion, like more options to do. Like some people, for example, they might have been one of those unlucky ones that, they've always had back problems and they just found being in clinic just too demanding. They can't stand the pace, they get tired and they get drained by people because people, talk about their problems all the time. And some people just kind of go, this is really tough stuff. So it gives them an opportunity to remain an osteopath, but direct their skills elsewhere. But where's it going in New South Wales? I'm not quite sure. It's a bit foggy, isn't it, at the moment? I'm not quite sure where osteopathy is going. I mean, we've got the course in New South Wales for Queensland. We don't have an osteopathic course here in New South Wales or Sydney particularly, and we should. That's and I'm still not quite sure why we lost it in UWS. It was down to politics, I was told, but I don't think so quite. We need a course here.
Yeah, there's a huge chasm at the moment. There's a bit of a gap there, and I guess it's important because it's important for the expansion of the profession. You're totally correct in saying that it's great opportunity that we're getting into other areas of work, of looking at occupational health and safety, getting into hospitals, but as a purist, and I mean it's great that that's happening, but obviously for the profession to expand, we need to have an expansion of private practice. That's just been the observation for other professions, physiotherapy, chiropractic, and the market needs to expand. And Sydney is the largest market in the country, and not to have a course here is a real shame. And I'm not blaming anyone else except us. We have to bear that responsibility as a profession. And I think that it has to be the priority at the moment for our organisations, our professional lobbies, our associations. It's really has to be driven by the profession. We can't expect it to just be given to us on a silver platter. We've got to go out there and make it happen.
I think in part as well, that's it's the modernization of everything. Well, osteopaths in the 90s, when I was here, we all knew each other, and you'd see each other, because the only education you could get, like postgrad education, was face-to-face. There was no such thing as webinars. And, there was council meetings every few weeks. Everybody used to hang out socially. We used to have we used to all hang out socially an awful lot.
Yeah.
And you don't hear of that now.
Yeah, that's a shame. That's a shame. I think obviously COVID kind of
even before COVID, that had all stopped, because because of webinars and Zoom stuff, which is really, really good. But I sort of felt that that's when we talked as a profession and got decided things and got the push on.
Well, it could be something for us to discuss and maybe reignite. And do you see any what are some of the challenges now with, say, the new graduates that you're seeing? Are you in contact with new graduates?
Yeah.
And so are you seeing any challenges at the moment in terms of quality, in terms of what they're telling you, what they're struggling with? What are you seeing at the moment? What do you see as some of the issues?
I think a few of them struggled with the way the unis have been set up now. I think it used to be 3 separate terms, and now it's like 6 terms. And I think they're finding just or not just the osteos, they're finding that quite hard to adapt to, because I think they needed those holiday times in order to earn and work. But now there's shorter, more periods when they're at uni. That seems to be a bit of a disruption for them. What are they facing? I suppose the ones we always did, got to pass my exams and find work. I don't think there's any problem with any of them finding work. There's plenty out there.
Plenty of work out there, yeah.
Plenty of work out there. But it has changed. That the common thing I hear the most is that, fair enough, lifestyle, they don't want to work the long hours that we do. They want to be able to sort of pick and choose a little bit more, and I kind of agree with that, because sometimes I'll, it was a few years back, I was like, I'm not doing these long days, and I'm going to do short days just to give myself a bit of a break.
Yeah.
And that was quite nice. I quite liked doing that, sort of doing a 7 till 12, say. And then you got the afternoon, but now I was working in the wintertime. You've got nothing to do. I thought, may as well just go back into the clinic.
Well, I guess if you're busy and you can make that choice, why not?
Yeah. So I think it's the same things we've always had to deal with. I think for them, though, it's also,
in terms of clinical
rising costs of living seems to be a daunting factor. It wasn't quite the same for us, but
in terms of clinical practice itself, being in the clinic, seeing patients, taking histories, are you seeing any anxieties there? Are you seeing any kind of like concerns, questions? What do they talk to you about? What are the questions that you get? Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So the 2 best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So for more information, please see the show notes. Now, enjoy, and back to the show.
It was. I suppose it's still.
Is it still the issue of just
confidence?
Confidence, right?
Confidence about how to speak to a patient, and how to say whether they should come back in a few days' time, in a day, in a week's time, and just. They're kind of going. You often get patients who want to bolt for the blue. Go, I think I've had enough. I'm not better in 3 treatments, and how to corral that and go. Well, no, it's if you go now, and I don't recommend it. It's an unwise choice. I say I say to them, say to the patient, would you stop your dentist halfway through a procedure? Go, I think I'm all right from here on in. You wouldn't, you wouldn't. You see it through to the end. I think that's what seems to be coming back the most.
And in terms of them knowing what to do, like putting a treatment together, how do you actually,
I think the COVID graduates have been a bit stuffed around because they didn't get the face-to-face. It all got very broken up for them, and I think they didn't quite get the clinical hours, and I think they're feeling a little bit dislocated. They're all sturdy lot; they'll get it, but I think they're slower to their confidence is a bit was impacted.
All right.
That's what I've seen.
All right. Well, what we'll do now is we'll say thank you to Alison for our listeners, and what we will do is we'll.
I do have one other thing to say.
Of course.
Just you did ask me, I didn't quite answer it. Is how do I go about seeing a patient? I always go and get them from the waiting room.
Yes.
To see how they get out the chair, to see their faces.
And yes.
And then sit them down, and I never say, "Oh, put this gown on, and I'll be back in a minute." I'll sit them down, or if they can't sit down, I'll say, "Looks like you can't sit down. You can stand," and I'll spend a good 1 to 4 or 5 minutes talking to the patient about how do they feel for the treatment, and often do follow up with a text anyway. Doesn't harm anything. And ask them what's happened in the intervening week, or 2 weeks or 3 weeks, and has anything changed in the medical history of general health? And my little quip is always, they always say a week is a long time in politics, and I say it's also a long time in health. What has changed? What's been going on? And I sit down and find out what's going on in their life as well before I say, right, get your gown on. And then, even then, I never have a patient lying down. I always have them standing.
Right.
I never say, get the gown on and lie down.
No, that's right.
At all. And I still am quite vocal with any osteo who has a massage therapist working for them, who, they just walk in, the patient's lying down. They don't know what's been going on. They're just lying down. They know they've had open heart surgery 3 weeks ago. They're lying down. They're not answering. Off we go. I'm very vocal about that. Always look at your patient's face. Do a standing examination, seated examination. Do every time. I still do a range of motion, lumbar range of motion. All the time.
Back to basics. Never fails you.
Always do lumbar range of motion, and and then clinical testing, but I'll do it and I'll repeat it, and I'll still do, if I did straight leg raising last week, I'll do it again this week, and I'll write it all down. I still do a lot of testing, and then I'll treat them. But I don't feel that if I'm seeing them for half an hour, they've got to get half an hour of treatment. They're with me for half an hour, and that's, they have to know they sit down and we talk first, we work it, and I work it all out, chat with them, ask them their opinion and how they're going, and then that molds what I'm going to do then.
And so in terms of treatment time, I mean, that might vary for you, right? For different patients, depending on what they need, how acute they are, how chronic they are, what kind of techniques you're using.
Yeah, I do like a half an hour list or an hour for new patients. Actually, they all get to decide when they book in. They get option of initial treatment 1 hour, initial treatment half an hour, subsequent treatment half an hour, an hour. But I'll direct the subsequent. I'll say, look, come in for half an hour. And other ones I sort of say, look, I feel I need longer. Let's allow for an hour, but it might be like 45, 50 minutes.
Yeah. And in terms of that, though, I mean, you find that once you do what you need to do, are you happy with just saying, well, look, that's enough? I think we've gotten what we need to get out of today.
Yeah, that's that skill of when to end a treatment. Yeah. When do you end? And I sort of go, and if it has pulled in like 15 minutes short of the half hour, I'll say, look, I really feel we've got enough done. That's enough for you today. And I say to them, look, I'll adjust the fee accordingly. I won't sort of say I'll hit you up with, the full half hour, because I've said, I think that's enough. But that doesn't happen very much.
You're very nice. You're very nice.
Oh, patients like that. Otherwise, I've got patients go, well, I had one the other day. She said, you were 2-3 minutes short the other day. I was like, I felt like saying, but you've benefited from me giving you extra 10 minutes before an hour. So I'm just going to So he's like, not saying a thing.
That
But you do
sounds-
get people like that. And it's just part of what I do. I sort of say, look, you know, it hasn't quite been up to the full hour, say it's like 50 minutes, but just knock it a little bit off for that. It just keeps people happy and keeps the relations going.
Do you think, though, they should be paying you for your time, for the result that you're giving them?
Oh, for the result.
100%.
But they see it as the time and result.
Yeah.
The patients will see it as the time. If they've booked in for half an hour, they want their half an hour, unless you come in and go, that's all you need. You know, I'll sort of say, you know, particularly if somebody's like really autoimmune and really allergic and the skin starts to redden up and they get really edematous, I'm like, whoa, back off. I'll go, I'm not doing any more. That's enough. Any more than that, your body's just going to react. We're not going to go far.
Yeah. All right. Well, that's a good place to, I think, end for our listeners in terms of what we're putting out there for the podcast. What I will do is continue this conversation with Alison for another 10 or 15 minutes or so for the Success in Practice program students. So thank you, Alison, for doing this.